1, 2,
And review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
You know, I think you expect modern medicine to act kind of like a scalpel, right?
Oh, absolutely. Highly specialized tools.
Yeah, exactly. When you open a medical toolbox today, you're anticipating these like highly engineered instruments, drugs designed to target just one specific receptor or, one exact pathway to fix one precise problem.
Right, the targeted therapies.
Right. But if you reach a little deeper into that same toolbox, like maybe into the bottom drawer, you pull out a sledgehammer. And it's heavy, it's blunt, and it swings wide.
It hits everything.
It really does. So today we are doing a deep dive into one of the most famous pharmacological sledgehammers ever created, chlorpromazine. We're putting on our clinical pharmacist and expert nursing instructor hats today to really extract the high-yield stuff for you.
Which is really the only way to tackle a drug like
Oh,
that.
for sure. And we're applying the Pareto principle here, so finding that crucial 20% of the clinical data that delivers, 80% of the understanding you need for nursing school, your clinical practice, and obviously NCLEX-style testing.
And that is the ideal approach for a drug this complex. So, chlorpromazine, which a lot of people recognize by its classic brand name, Thorazine.
Oh, yeah, Thorazine.
Right. It's fundamentally a first-generation antipsychotic. It belongs to the phenothiazine class. But because of its really broad physiological reach, it also functions as a highly effective antiemetic.
Meaning it stops severe nausea and vomiting.
Exactly.
Okay, so handling severe psychosis and severe nausea, those seem like two completely different jobs for one single molecule.
They really do.
So if we're looking at the mechanism of action, the MOA, what is the underlying link there? Like, what is this drug actually doing inside the brain?
Well, the primary mechanism revolves entirely around dopamine. Chlorpromazine aggressively blocks postsynaptic dopamine receptors, specifically the D2 receptors.
Okay.
And it concentrates this blockade in the mesolimbic system.
Okay, wait, the mesolimbic system, that's the brain's reward and salience pathway, right? Like it dictates what we pay attention to and what actually feels significant to us.
Yes, exactly. So in severe schizophrenia, dopamine transmission in that specific pathway is just hyperactive.
So the brain is basically assigning massive significance to things that aren't actually real.
Right. Which manifests as, the hallucinations, the delusions, severe agitation. So by blocking those D2 receptors, chlorpromazine essentially just turns down the volume on that excessive dopamine signaling.
Got it.
And that dampening correlates directly with its expected antipsychotic therapeutic effect.
Wait, I have to ask about that, though. If it's blocking dopamine, which is, our primary reward and motivation chemical, doesn't that leave the patient feeling completely flat or, depressed?
It does.
How does the brain handle that set or drop?
Well, that's actually a major clinical challenge because you aren't just selectively stopping the hallucinations. You are globally reducing dopamine activity in that area.
Wow.
So it can lead to a flattening of affect, a total lack of motivation, or just a feeling of emotional emptiness. The drug just doesn't possess the precision to only target the quote-unquote psychosis dopamine while leaving the happiness dopamine alone.
Yeah, that makes sense. So instead of just calling it a neurological stop sign, it sounds more like a lock and key mechanism. Like the dopamine receptor is the lock, dopamine is the key, and chlorpromazine is essentially cramming a wad of heavy tape into the keyhole.
Tape in the keyhole, I like that.
Right. So the real dopamine just can't get in.
That analogy perfectly captures receptor antagonism. And the thing is, it does that exact same tape in the keyhole routine in another crucial area called the chemoreceptor trigger zone, or the CTZ.
The CTZ, that's the brain's nausea center, right? Like it sits just outside the blood-brain barrier, so it can actually sample the blood for toxins.
You're right. So when the CTZ detects something toxic, it uses dopamine to send a signal to the vomiting center to, expel the stomach contents. So by blocking dopamine receptors right there in the CTZ, chlorpromazine halts that signal entirely.
Okay, but looking at the pharmacology data, it doesn't just block dopamine. It also possesses really strong anticholinergic effects, and it blocks alpha-1 adrenergic receptors.
It does, yeah.
Let's break those down because alpha-1 receptors are part of the sympathetic nervous system, right? They keep our blood vessels constricted so we maintain our blood pressure.
Right.
So if this drug is blocking them, the vessels must just, dilate and relax.
They do. And that dilation is exactly why patients experience profound orthostatic hypotension.
A massive drop in blood pressure.
A massive drop, especially when they're changing positions. The blood vessels just lose their tension, and gravity physically pulls the blood down into the legs.
That's terrifying.
It is. And it also triggers a reflex tachycardia, because the heart suddenly senses that drop in pressure and just starts beating faster to try and compensate.
Gotcha.
Plus, that alpha-1 blockade is responsible for a significant amount of the sedation and the muscle relaxation you see.
Okay, and what about the anticholinergic effects? Because acetylcholine is the neurotransmitter for the parasympathetic nervous system, the whole rest and digest thing.
Right. So when you block acetylcholine, you are essentially drawing the body out and slowing down its secretions.
Okay.
You see xerostomia, which is severe dry mouth, along with urinary retention, blurred vision, constipation.
So just to recap the expected therapeutic actions here for everyone listening, we are calming the mind, settling the stomach, but at the heavy cost of lowering blood pressure and drying out the entire body.
That sums it up perfectly.
So given all of that, the clinical indications must be incredibly broad. Obviously, we know about acute and maintenance treatment for schizophrenia and severe nausea and vomiting.
Right.
That includes presurgical nausea, and I saw it's even used as a very last-line option for pregnancy-induced nausea.
It is. It's also used a lot in pediatrics,
Right.
specifically for children with severe behavioral problems or conduct disorders or ADHD. Yeah, children who are displaying explosive aggression or just excessive motor activity. I mean, it's a heavy-duty option.
I'll say.
But by dampening that dopamine transmission, it reduces combativeness that is just entirely out of proportion to the situation.
Wow. Okay, I really want to pivot to the off-label and niche uses here because these highlight just how fascinating this drug is. Intractable hiccups,
Yes.
also known as singultus. How does a heavy-duty schizophrenia drug cure hiccups?
Well, hiccups are actually a really complex reflex arc. They involve the brainstem and the phrenic nerve, which controls your diaphragm.
Okay.
And it turns out dopamine modulates that reflex arc. So when someone has severe hiccups that last for days and exhaust them, and they just don't respond to typical treatments.
Which sounds like an absolute nightmare, by the way.
Oh, it's awful. But blocking dopamine with chlorpromazine disrupts that reflex loop and basically breaks the spasm cycle.
That is wild. The clinical protocol is also listed as an adjunct treatment for tetanus. And tetanus causes those terrifying life-threatening muscle spasms and rigidity.
Right. And because of the drug's muscle relaxant properties, which is largely driven by that alpha-1 blockade and its effects on the basal ganglia, it reduces that rigidity.
Okay.
It's typically given alongside powerful sedatives, like barbiturates, to keep the patient from literally tearing their own muscles during a tetanus spasm.
Wow.
It's also used to manage the severe neurovisceral pain associated with a really rare metabolic disorder called acute intermittent porphyria.
Those niche uses are such a great reminder of its versatility, but let's actually trace how it moves through the body, right?
Yeah.
The pharmacokinetics.
Sure.
If a patient swallows a chlorpromazine tablet, the bioavailability is surprisingly low. I read only 32% of the drug actually makes it into systemic circulation.
Yeah, and that low number is strictly due to massive first-pass metabolism.
Okay.
When you swallow a pill, it's absorbed through the intestines and travels directly to the liver via the portal vein before it ever even reaches the heart or the rest of the body.
So the liver basically gets the very first crack at it.
Exactly. And the liver views this chemical as a completely foreign substance. It heavily metabolizes or destroys nearly 68% of the drug right out of the gate.
Wow. But despite that massive filtration, the onset of sedation is still very rapid. Like, a patient taking it orally will feel sedated within 30 to 60 minutes.
Very fast.
But I want to highlight a massive clinical trap here for you guys listening. While the sedation is fast, the peak antipsychotic effects do not happen quickly.
Not at all.
Maximal improvement for severe psychosis can take anywhere from 6 weeks to 6 months.
And that is a critical distinction for clinical practice. You might administer a dose to a highly agitated patient who's experiencing psychosis. And an hour later, they're quiet, they're asleep.
Right.
It is incredibly easy to just assume the psychosis is resolved, but that immediate quiet is purely the alpha-1 blockade and the general sedation.
Just the sledgehammer side effect.
Exactly. The actual neurochemical remodeling, like the process where the brain adapts its dopamine receptors and stabilizes the psychosis, that requires weeks or months of consistent therapy.
Got it. And the liver's role in this drug's journey doesn't stop at first-pass metabolism either. It breaks the drug down using primarily the CYP2D6 enzyme, and apparently it creates over 100 different metabolites.
Over 100, yeah. Some of which are pharmacologically active themselves.
Really?
Yeah, one metabolite, 7-hydroxychlorpromazine, is highly potent. And there's a super unique physical manifestation linked to how the body handles these metabolites.
Oh, the skin thing.
Yes.
Yeah.
They can accumulate in the skin, and when they're exposed to ultraviolet light from the sun, they actually interact with melanin to cause this distinct, like, gray-blue hyperpigmentation.
Wow, so the patient's skin actually turns blue-gray. The systemic impact here is just immense. And since 99% of the drug relies on the liver to be broken down and clear, with only like 1% excreted unchanged in the urine, the drug interactions, the DDIs, they must be highly complex.
They are. Because chlorpromazine inhibits that exact same CYP2D6 enzyme it uses for its own metabolism, it slows down the breakdown of other medications that rely on that same pathway.
So it causes those other drugs to just build up in the bloodstream.
Precisely. Furthermore, because of its broad receptor blockade, it dramatically prolongs and intensifies the effects of anesthetics.
Meaning, if a patient is going into surgery and you are administering this for presurgical nausea, the anesthesia team absolutely needs to know.
Without a doubt. The dosages for treating nausea during surgery are intentionally much lower.
Right.
If you give a standard dose, the chlorpromazine could just supercharge the anesthesia and push the patient right into cardiovascular collapse.
Which brings up a really critical safety demographic. There is a glaring black box warning on this. The strictest warning issued by the FDA, and it's regarding geriatric patients. Why is this drug so incredibly dangerous for older adults?
Well, chlorpromazine is strictly not approved for treating dementia-related psychosis in geriatric patients. And that's because it significantly increases their risk of morbidity and mortality. When older adults with dementia receive this drug, we see a much higher incidence of fatal cerebrovascular events, like strokes, as well as death resulting from heart failure, sudden cardiac death, and severe infections.
Is that just because an aging brain and cardiovascular system simply can't handle the massive autonomic swings?
That is a major part of it, yes.
Yeah.
The profound hypotension combined with that heavy anticholinergic burden is incredibly taxing on an older heart.
That makes sense.
Plus, the deep sedation suppresses their gag reflex and their mobility, which frequently leads to fatal aspiration pneumonia.
Wow. And this aligns perfectly with the Beers criteria, too, which flags it as a potentially inappropriate medication for the elderly in general.
Right.
And it also notes that it should be completely avoided in patients with a history of syncope or falls. I mean, if a patient already struggles with fainting, giving them a drug that drops their blood pressure when they stand up is just asking for a fractured hip.
Absolutely. It is also contraindicated in patients with Parkinson's disease.
Oh, because Parkinson's is inherently a disease of dopamine depletion in the brain?
Right. So giving a powerful dopamine-blocking drug to a Parkinson's patient will rapidly worsen their motor symptoms and rigidity.
Of course. And we also need to be extremely cautious with hepatic impairment, right? If the liver is diseased, it can't perform that vital metabolism, leading to rapid drug toxicity.
Exactly.
And I also saw infants under 6 months should generally not receive it unless there are literally no other options for a potentially life-saving intervention.
Correct. The risks are just too high.
So we need to dive deep into the side effects and adverse reactions. The difference between, like, an annoying side effect and a life-threatening adverse reaction is everything for nursing students and clinicians here.
It really is.
We already covered the common side effects, the drowsiness, the anticholinergic dry mouth, the alpha-1-driven orthostatic hypotension, and that photosensitivity that causes severe sunburns and the hyperpigmentation. But let's unpack the serious, stop-everything clinical emergencies. Let's start with NMS, neuroleptic malignant syndrome.
Okay, NMS. It is rare, but it is highly fatal. It occurs when that sudden drop in dopamine signaling hits the hypothalamus, which is the brain's thermostat. The body basically loses its ability to regulate temperature and muscle tone.
Oh, wow.
So the classic presentation is a dangerously high fever, often over 104 degrees Fahrenheit, combined with severe, quote-unquote, lead pipe muscle rigidity.
Lead pipe rigidity.
Yes. Plus, altered mental status and severe autonomic instability where their heart rate and blood pressure are just wildly fluctuating.
So if you see a patient present with a soaring fever and rigid muscles while on this drug, it is an immediate medical emergency.
Drop everything, yes.
What about the long-term movement disorders?
That would be tardive dyskinesia. So when you block dopamine receptors for months or years, the brain eventually tries to compensate by making those receptors hypersensitive.
Okay.
This results in delayed, involuntary, and repetitive muscle movements, most commonly in the face, mouth, and tongue.
Like the lip smacking or grimacing.
Exactly. And the terrifying part is it can become permanent, even if the drug is stopped entirely.
Man. Okay, let's look at the cardiovascular system. We talked about blood pressure. But this drug also alters the heart's electrical rhythm, right? It can cause a prolonged QT interval on an EKG.
Yes, it can.
And for those listening, the QT interval is basically the time it takes for the heart's lower chambers, the ventricles, to electrically reset for the next beat. It's kind of like a camera flash charging up.
That's a great way to think of it. And chlorpromazine delays that reset. If you delay that electrical recharge for too long, the heart's rhythm can literally descend into total chaos.
Oh, no.
It triggers a specific fatal arrhythmia known as torsade de pointe. The heart just stops pumping blood efficiently and essentially just quivers.
That is terrifying. It also attacks the immune system, right? Causing a granulocytosis.
Yes, it can cause systemic toxicity to the bone marrow, which severely depletes white blood cells. This leaves the patient entirely defenseless against even really minor infections.
Wow.
A simple sore throat or a mild fever in a patient on this medication must be investigated immediately.
Okay. It also lowers the seizure threshold, making patients a lot more susceptible to convulsions. And finally, it can trigger SIADH, the syndrome of inappropriate antidiuretic hormone secretion.
Right. So the drug causes the brain to release too much antidiuretic hormone, which signals the kidneys to hold on to free water.
Okay.
This excess water dilutes the blood, leading to dangerous hyponatremia, or critically low sodium levels, which in turn can cause brain swelling, confusion, and even further seizures.
So with a risk profile this extensive, the nurse at the bedside is really the ultimate safety net. Let's transition into nursing interventions and administration rules. What is the absolute priority assessment before and during administration?
Blood pressure monitoring. It is non-negotiable.
Okay.
This is especially vital when administering chlorpromazine intravenously or intramuscularly. The clinical rule is extremely rigid. The patient must be placed in a recumbent position, meaning lying completely flat, and remain there for at least 30 minutes following an IV or IM injection.
Because if you let them stand up while those alpha-1 receptors are acutely blocked, their vascular system won't constrict to fight gravity. The blood just pools in their legs, their brain loses perfusion, and they will collapse.
Exactly. And when it comes to the actual IV administration, there's a very strict safety protocol. You must never inject undiluted chlorpromazine directly into a vein.
Never undiluted.
Never. It is highly irritating and can cause massive localized tissue damage or even immediate cardiovascular collapse. It must be diluted with 0.9% sodium chloride to a concentration of 1 milligram per milliliter.
Got it. And the push rate is heavily restricted too, right?
It has to be pushed incredibly slowly with a maximum rate of 1 milligram per minute for adults. And before you push it, you also need to visually inspect the fluid.
Okay.
A slight lemon yellow color is totally normal, and it doesn't alter the drug's potency. However, if the solution is markedly discolored or dark, you must discard it.
Good to know. And for intramuscular injections, dilution isn't strictly required, but the technique really matters.
Right. It must be injected slowly and deeply into the upper outer quadrant of the buttock because it's such a tissue irritant. Ensuring a really deep intramuscular delivery prevents painful surface complications.
Okay, as for laboratory monitoring, based on those adverse effects we just unpacked, nurses must track sodium levels closely to catch that SIADH early.
Yes, definitely.
They also need to monitor liver function panels and visually observe the patient for jaundice, like that yellowing of the skin or the sclera of the eyes. If jaundice appears, the therapy usually has to be discontinued because it signals liver failure.
Exactly right.
Let's talk about the patient's perspective real quick. If someone is managing this medication at home, what does their education look like?
For oral doses, they can take it with or without food. But honestly, because of the gastrointestinal side effects, taking it with a meal is highly recommended just to prevent stomach upset.
Oh, and there is a remarkably practical tip in the pharmacology data regarding rectal administration. While the suppository form is largely discontinued in the US, if a patient is using it and the suppository has become, too warm and soft to insert...
You should chill it in the refrigerator for 30 minutes or run cold water over it before actually removing the wrapper.
I just love that. That kind of practical guidance is so essential for adherence.
It really is. But the paramount focus of patient teaching just has to be safety.
Yeah.
You have to educate them about the melanin interaction and the photosensitivity.
Right.
They need robust sun protection, sunscreen, long sleeves, hats. Furthermore, you must drill the reality of orthostatic hypotension into their daily routine.
Yes.
They have to change positions in stages. Sit on the edge of the bed for a minute before standing. If they jump up too fast, they will fall.
Absolutely. Okay, we have covered the mechanisms, the risks, and the real-world application. Let's pull all of this together. If someone listening is heading into a clinical shift or preparing for a pharmacology exam, we need to distill this into the ultimate recap. Let's do the 12-point summary.
Sounds good. Let's start with the absolute priority. The must-know intervention is cardiovascular safety. Always monitor blood pressure closely with IV and IM routes. Ensure the patient is lying flat for at least 30 minutes post-injection. And never push the IV form undiluted.
Never undiluted. Got it. For the nice-to-know category, remember those fascinating niche indications. Because it modulates reflex arcs and causes muscle relaxation, it's used for intractable hiccups and as an adjunct for tetanus.
And the major test trap involves the therapeutic timeline. Do not be fooled into thinking the psychiatric effect is rapid just because the patient falls asleep quickly.
Right.
The sedation hits in 30 minutes, but the neurochemical remodeling required for peak antipsychotic improvement takes between 6 weeks and 6 months.
Okay. And the ultimate clinical red flag is the black box warning for increased mortality in elderly patients with dementia-related psychosis. Plus, you must constantly assess for those fatal adverse effects, the fever and rigidity of NMS, the prolonged QT interval, and the infection risk from a granulocytosis.
And if we were to summarize all of this into a single memory hook, it would be: chlorpromazine blocks dopamine to calm the mind and the stomach, but watch out for the dangerous blood pressure drop and the black box warning in the elderly.
That perfectly encapsulates the Pareto principle we aimed for today. Thank you for joining us on this high-yield deep dive into clinical pharmacology. We really hope this breakdown clarifies the mechanisms behind the facts and leaves you feeling far more prepared for patient care and your exams.
Absolutely.
And as we wrap up, I want to leave you with a final thought to mull over. We started today by contrasting modern medicine's precise scalpels with this drug's broad sledgehammer approach. Chlorpromazine swings really wide. It forcefully blocks dopamine, alpha-1, and cholinergic receptors all at once.
A huge impact.
Right, and that messy multi-system blockade is exactly why it can treat everything from severe schizophrenia to intractable hiccups, but it is also the exact reason it causes such immense sweeping side effects like the hypotension and the tardive dyskinesia.
Exactly.
So as medical science continues to engineer perfectly targeted single receptor medications with far fewer side effects, will these older, broad-spectrum sledgehammers eventually become entirely obsolete? Or will their versatile multi-system impact always hold a unique, irreplaceable role in emergency medicine when the clinical picture is chaotic and you just need something powerful enough to reset the system? Something to think about. Until next time.